Let's start with the obvious. Asthma is going to be one of the most frequent conditions you'll see in your career. After all, over 300 million people in the world suffer from it. So we should probably talk about what asthma is and how to manage your patients with chronic asthma. Since we're focusing on the clinical presentation and management of asthma here in Sketchy IM, we're going to skip past definitions and pathophysiology and head straight into a snow day at Alvin's house. If you need an in-depth review of the pathophys of asthma, check out our asthma and bronchiectasis sketchy path sketch. And see the third sketch in our Sketchy IM series on asthma for the presentation and management of acute asthma exacerbations. Asthma is an airway disease defined by a triad of processes: airway inflammation, airway hyperresponsiveness, and reversible airflow obstruction. Here at Sketchy, our recurring symbol for reversible airflow obstruction is the pink reversed hat. I don't know what you did, Alvin, but Mom is getting hyper angry at your choice of haberdashery. The classic set of symptoms in asthma includes cough, dyspnea, and wheezing, represented by the loud party blower being used by that snowman creeper. Asthma-related cough is usually worse at night and may, in fact, be the only presenting symptom. Make sure to think about asthma in patients with chronic cough, especially when it's nocturnal, seasonal, or related to a specific trigger. One key historical feature to ask for are triggers, which are substances or activities that trigger a patient's asthma symptoms. Triggers are such an important piece of history to obtain that we've drawn the snowball launcher with a huge trigger to remind you to ask about them. The most common asthma triggers include respiratory infections, exercise, allergens such as pollen, dust, or pet dander, environmental irritants like cold air or cigarette smoke, and medications. Two medications in particular are especially worth asking your patient about: aspirin and beta blockers. Aspirin can trigger bronchoconstriction in asthmatics via leukotriene dysregulation. As a COX inhibitor, aspirin causes increased formation of leukotrienes, a substance implicated in the pathogenesis of bronchospasm. At Sketchy, our recurring symbol for aspirin is the ASA Umpire chest protector, this time donned by our snowball launcher toting kid. He sure came prepared. Another medication trigger to ask about are beta blockers, which can cause bronchoconstriction by blocking beta-2-mediated bronchial smooth muscle relaxation. Makes sense, since we use beta agonists to treat asthma. But we'll save that for our next sketch dedicated to asthma management. For now, let the snowman head blocking the bell of that beta-2 tuba remind you that beta blockers can trigger asthma. Look, I can't wait for the new episode tonight. Of what? I'm not sure, but excitement's excitement. The newspaper in the driveway is to remind you that asthma symptoms are most commonly episodic, with many patients having long asymptomatic periods in between acute symptoms lasting hours to days. These symptoms are also usually worse at night, and typically resolve with asthma medications or avoidance of the specific trigger. If your patient says they only have symptoms at work, think about occupational asthma. In these cases, the asthma trigger is only present at work, like a chemical allergen or particle. So patients only have symptoms at work. This is about the only time someone can seriously say they're allergic to work. Yeah, laugh it up, you hams. Make sure to ask about a personal or family history of atopy, atopic dermatitis, aka eczema, allergic rhinitis, or food allergies. Since there's a significant atopic component to the pathophysiology of asthma, atopic patients are much more likely to have asthma in addition to their other conditions. That's why we've drawn in this rashy family with runny noses walking by all the carnage. All right, let's move on to the objective findings in asthma, starting with the physical exam. The most prominent abnormality on exam, if you find any at all, is wheezing, represented by our recurring Sketchy symbol, the loud party blower in that snowman's mouth. Asthma wheezes are most commonly heard on expiration, widespread, heard throughout both lungs, and polyphasic, having different pitches, tones, and durations, which is why the snowman's party blower is multicolored. These findings occur because asthma is a process of dynamic airflow obstruction that can change from minute to minute and involves the whole lung. So it makes sense that symptoms will be dynamic and involve the whole lung too. The airflow obstruction in asthma also causes prolonged expiration since the constricted airways makes it harder for patients to blow out all the air in their lungs. At Sketchy, prolonged expiration is represented by the extra long party blower in that other snowman's mouth. As a refresher, expiration normally takes twice as long as inspiration. An I to E ratio of 1 to 2. Anything longer than 1 to 2 is considered prolonged expiration. Of course, because the airflow obstruction in asthma is dynamic, patients often have a completely normal lung exam. But don't let that normal, happy snowman fool you into thinking nothing's wrong. Don't just stop at the lungs. Look for signs of atopy on physical exam, such as the itchy red, lichenified plaques of atopic dermatitis, or the pale and swollen nasal mucosa or pharyngeal cobblestoning of allergic rhinitis. Finding these atopic signs can increase your confidence in a diagnosis of asthma. At Sketchy, allergic rhinitis is represented by a runny, drippy nose, and eczema by the red rash on that mailman. Good for you, sir. Let neither cold nor itchiness nor snowman army keep you from delivering the mail. The presence of nasal polyps, which are glistening gray mucoid masses in the nasal cavities, represented by the bumpy gourd nose on that snowman, should raise suspicion for aspirin-exacerbated asthma. In addition to the physical exam, the cornerstone of asthma evaluation is pulmonary function testing. Need a refresher on what PFTs are? Check out our PFTs how-to sketch. Let's review the asthma-specific highlights so you can look like a pro in front of your attending. As you know, asthma is an obstructive lung disease, which means the classic spirometry findings common to all obstructive lung diseases will also be true for patients with asthma. Specifically, those findings are a characteristic scooped airflow pattern and an FEV1 to FVC ratio of less than 0.7. However, unlike COPD, the airflow obstruction in asthma is dynamic and reversible. That's why the driver of that spirometer-shaped snowplow is wearing a reversed pink hat. What this means is that on spirometry, asthma patients will see significant improvement in their airway obstruction with the administration of bronchodilators. This is known as a positive bronchodilator response. A positive bronchodilator response in asthma is defined as an increase in FEV1 of 12% or more after administration of albuterol. Watch out, kid, before you get run over. Reversible airflow obstruction strongly suggests asthma over COPD. That's because asthma is caused by bronchospasm and airway constriction without underlying lung tissue destruction. So dilating the airways with albuterol should improve and sometimes relieve the obstruction. Additionally, DLCO should be normal in asthma since there's nothing structurally wrong with the lungs. If all of these terms make no sense to you, head on over to our PFT how-to sketch for a refresher. Don't have time or access to formal pulmonary function testing? You're in luck. Measuring peak expiratory flow rates, aka peak flows, is a quick and dirty way to assess airflow obstruction that can be done virtually anywhere. At Sketchy, peak flows are represented by the peak flow snowblower with a suspiciously tuba-shaped outlet. Peak flows measure the flow of air during a short, forceful exhalation. Tell the patient to take a giant deep breath in, put the meter to your lips, and blow out as hard and as fast as you can. Take the highest result from 3 tries, and that's your peak flow. An improvement in peak flow more than 20% after administration of albuterol is suggestive of asthma. However, peak flows are not specific, so they are not a substitute for formal spirometry testing to diagnose patients with asthma. Over long periods of time, patients with long-standing, poorly controlled asthma can eventually develop permanent airflow obstruction from chronic airway inflammation. At that point, they behave similarly to COPD patients, with their obstructive lung disease becoming irreversible despite the administration of bronchodilators. Much like that spirometer-shaped snowplow irreversibly stuck in the snowbank next to that no U-turn sign. One last thing you might hear about: bronchoprovocation testing. In this test, patients are given a provocative stimulus, such as methacholine, to trigger bronchoconstriction and a subsequent 20% drop in FEV1. Since asthma is defined by airway hyperreactivity, patients with asthma should get there with a much smaller dose than normal patients. Bronchoprovocation testing is generally used to diagnose patients with atypical presentations, such as patients with classic asthma symptoms but normal spirometry results. That's why we've drawn in this atypically dressed methacholine marathon runner huffing and puffing with her February 1 bib falling down. Oh, so much dedication, though. So you're pretty sure it's asthma. What other conditions should you be watching out for? Let's briefly review the differential diagnoses for the classic symptoms of asthma: wheezing, dyspnea, and cough. First things first, burn this mantra into your head. All that wheezes is not asthma. While asthma is the most common cause of wheezing, wheezing is simply a sound made by air moving through narrowed luminal areas anywhere along the respiratory tract. Therefore, anything that causes airway narrowing can produce a sound just like wheezing. Many diseases, such as COPD, pulmonary edema, anaphylaxis, and thoracic tumors can also cause wheezing. Coincidentally, these conditions also typically cause dyspnea. So check out our acute dyspnea and chronic dyspnea DDX sketches for more info on these conditions. In patients older than 50 presenting with asthma-like symptoms for the first time, think about other common conditions such as COPD and heart failure. Asthma still occurs, but it's a young man's disease and is much less likely to present for the first time in older adults. If you suspect heart failure, look for jugular venous distension and peripheral edema. Listen for extra heart sounds such as an S3 and S4. And look for an elevated BNP level and pulmonary edema on chest x-ray. In patients with significant smoking history, more than 20 pack years, COPD is more likely. Take another look at those spirometry results. They shouldn't show significant improvement in FEV1 with the administration of a bronchodilator. On the other hand, wheezing, a history of frequent respiratory infections, symptoms of GI malabsorption, and nasal polyps on exam should make you think of cystic fibrosis. For all the details on conditions that can cause chronic dyspnea, check out our dedicated chronic dyspnea DDX sketch. Although asthma is one of the big 4 common causes of chronic cough, don't forget about the other 3. Upper airway cough syndrome, GERD, and ACE inhibitor-associated cough are just as, if not more common, causes of chronic cough. Fortunately, as you'll see in our cough DDX sketch, the way to diagnose these 3 other common causes of chronic cough is to treat empirically for those conditions. If their cough resolves, you've got your answer. If not, move on to the next cause on the differential. For upper airway cough syndrome, empirically treat with intranasal glucocorticoids and oral antihistamines. For GERD, empirically treat with an oral PPI. And for ACE inhibitor-associated cough, stop the drug and replace it with an ARB. Let's finish up by reviewing a few asthma plus syndromes to consider in patients with atypical or particularly severe asthma. Allergic bronchopulmonary aspergillosis occurs in patients with asthma or cystic fibrosis who develop an allergic reaction, hypersensitivity, to aspergillus. Patients present with difficult-to-control asthma plus elevated serum IgE and pulmonary infiltrates on chest x-ray. For more on aspergillus infection, check out our pneumonia in special population sketch. Eosinophilic granulomatosis with polyangiitis, aka Churg-Strauss syndrome, presents with asthma plus eosinophilia and signs of granulomatous vasculitis. For more details on Churg-Strauss, check out our small vessel vasculitis sketch. To recap, diagnosis of asthma requires the right constellation of symptoms, that is, episodic wheezing, cough, and dyspnea, usually in response to a trigger, such as an upper respiratory infection or cold air. Patients often have a personal or family history of atopic conditions like allergic rhinitis and atopic dermatitis. On spirometry, look for the classic obstructive airflow pattern, an FEV1 to FVC ratio less than 0.7, and an increase in FEV1 of 12% or more after administration of bronchodilators. You should also be confident that alternative diagnoses, like the ones we just covered, are unlikely. All right, let's sum up everything we've learned into a concise sample assessment statement. Miss A to P is a 27-year-old female with a history of allergic rhinitis and atopic dermatitis who presents for intermittent wheezing and shortness of breath that occurs once a week and wakes her up once a month at night. Physical examination does not reveal any wheezing or prolonged expiration on auscultation. There are no abnormal findings on her chest x-ray. Spirometry results show an FEV1 to FVC ratio of 0.65 with a 20% improvement in FEV1 after administration of albuterol. Given her symptomatology, atopic history, and spirometry findings, she most likely has intermittent asthma. That's all for now. Head on over to the next sketch, where we'll go over an in-depth review of the classification and treatment of chronic asthma.